So let's now talk about the basic anatomy for understanding injection technique into the shoulder, and especially regarding the shoulderotomy in glenohumeral injections, the injections in the AC joint, the dorsal injections, and finally the treatment, the sonoguided treatment of the calcific tendinitis in the shoulder. As we know, blind injections have poor accuracy to achieve and to arrive the glenohumeral joint, and the clearly advantages of the ultrasound guided injections are the mitigation of the radiation, the execution time, the cost effectiveness, and also the convenience for the physician, also for the patients. We have several studies that show us that the blind injections has accuracies about 26% in the study of Sethi, 10% only in the study of Jones. Under another study for Eustace, just up to 42, while injections, echo-guided, ultrasound-guided, goes in a study of Ratten just to 94 success, and with similar success with an anterior or posterior approaches. Regarding the glenohumeral injections, we know now that the ultrasound is essential just to ensure a correct approach during injections, and the treatment in such injections is just for adhesive capsulitis, for degenerative joint diseases, for aspiration of effusion, and or just to exclude septic or crystalline diseases in joint, and also for some articulate-sided rotator cuff diseases, and also for labral pathology. Regarding injections in glenohumeral joint, we have two main approaches and techniques, the anterior approaches or the posterior approaches. If we look after anterior approaches, the most used is just the approach through the rotator interval. As we know, rotator interval just between the anterior border of the supraspinatus and the superior border of the subscapularis. In that, this is our target. The main problem in such ultrasound guided approaches is that we can't see clearly the shoulder, the needle, because it's almost perpendicular to the joint. The glenohumeral approach through the rotator intervals, we see here through this lightning through the arthroscope, we see that the joint is almost always in line with the AC joint. The references are 1 centimeter inferior and 1 centimeter lateral to the AC joint, with the shoulder in extension, and with the needle a little bit oblique, 30 degrees in a superior inferior direction. We achieve the joint. There's another way, it's a little bit distal to the interval. This is just through the superior part of the subscapularis. We see through this lightning. The references here are 1 centimeter lateral to the coracoid process, and so about 2 centimeters to the AC joint. If we go perpendicular in this way, we will see and we will achieve the infiltration just in the articulation in the joint. The shoulder position is the same, and here we have not to make a little bit oblique the needle, just trying to maintain the needle so perpendicular as possible. As we see, as we can see, it's not possible just to see the needle, to control the needle with the ultrasound because of the perpendicularity from the needle to the joint. The only way we can use the ultrasound in this anterior approach is just for marking the position of the joint. As we see here, lateral to the coracoid process, we see here the needle. We put the needle between the skin and the transducer just to mark the position of the joint. And second, when we make our infiltration, we go 2-3 centimeters perpendicular, just in the depth of the joint, and we can control from posterior how the joint is distant, how the distension of the posterior joint space while we inject our medicament. This is why almost all anterior approaches are with indirect techniques. There are no way just to control clearly the needle from anterior. And this is why most of the people who make infiltration ultrasound guided make it with posterior or through posterior approaches. And in this case, we have also two ways just to position the patient in a prone position with the arm hanging out of the table, or in the sitting position with the arm just resting on the other shoulder. The posterior approach in this prone position that we make most, the shoulder has to be a little bit adductor and thus opening the glenohumeral joint space. We put the transducer just inferior and parallel to the spine of the scapula, and we use normally a long needle, a 7 centimeter long needle should suffice, depending on the size of the shoulder and also on the depth of the glenohumeral joint space. The target here is just to control the posterior part of the scapula, the labrum. We will pass through the infraspinatus and the deltoid, and just our target is the virtual space between the glenoid labrum and the humeral head. As we see, we can enter through a medial portal, also through a lateral portal, just both targeting the space between the labrum and the humeral head, as we see here on this schema. Important also the rotation of the arm. By inner rotation of the shoulder, the cartilage of the humeral head can be observed moving against the glenohumeral complex and against the labrum, and we see the whole cartilage in inner rotation. Thus we have more surface of the joint. Whether with external rotation, we see the tendon of the spinatus. Our target is not so big, but it's clearly better because the pouch is clearly, the capsule is clearly relaxed in external rotation and is tense in inner rotation. This is why we have to choose normally, we used to choose normally a middle position between inner rotation and external rotation. As we see here, when we rotate, the pouch is clearly not so big, while in internal rotation the cartilage emerges quite larger. But the pouch is clearly distant in external rotation and is clearly tense in inner rotation. Here, just to see, while when we see the cartilage, we are clearly over the joint space and under the tendon of the infraspinatus. The posterior medial approach is the most used because just the target, to get the target between the labrum and the humeral head, we go very perpendicular, yes, to the humeral head, so we always can stick the cartilage. As we said, always when we see cartilage, we are just inside the joint and through the capsule. As we see here in this arthroscopic view, the pouch on the posterior part of the shoulder is big enough. We have to be so close as possible to the labrum, to the posterior labrum. A little bit more, or a little bit closer to the labrum. If we stick the labrum, it doesn't be a big problem because it makes a little hole with a needle, but it's not so dangerous as we see when we go very close to the labrum. We can't damage the cartilage of the glenoid, only is just to stick the labrum or to stick the humeral head in the cartilage. This is almost the only pitfall of this posterior approach, is just to stick the cartilage. It's not so important just to stick it in the humeral head, and also to trespass the labrum on the posterior part. Another problem could be if we choose a needle that is not strong enough, because especially in inner rotation, the capsule is very tense, very tense, and it could happen that the needle just glide over the capsule and over the head, not going inside the joint. We can see when we inject, make our injection, first the distension of the joint, of the joint, and then distending the whole capsule, just superficial. First distension inside the joint, and second the distension in the capsule. Important is just to control, especially when we make the infiltration in inner rotation. Could happen that the capsule is so tense over the cartilage that the needle doesn't go through the capsule, and the injection is made just in the infraspinatus. We can see how the liquid is just going inside the infraspinatus, not inside the joint. We see how this is a very often mistake. In these cases, we have to reposition the needle, just going a little bit closer to the labrum, it's just going inside the joint, driving a little bit the needle and just pushing it a little bit more oblique, just inside the joint. The lateral is also the same. The transducer, the lateral posterior approach is the same one. The transducer is also positioned just underneath the spine of the scapula, about 2 centimeters lateral from the lateral border of the transducer, and going just inside the joint. The main problem is just that due to the convexity of the humeral head, we can very often glide over the head and not reaching the joint. If this happens, it is important to retrieve a little bit the needle and just make more in a rotation and go very oblique just inside over the cartilage, just to feel the joint from the lateral part, just going targeting the cartilage and not our pouch between the labrum and the head. Regarding the AC joint, in cases of degenerative or traumatic arthropathy, with a normal 21 gauge and 4 centimeters needle, we mainly and mostly make the infiltration just in the out of plane way. We put normally a needle between the transducer and the skin, just to mark the middle position of the AC joint, and then retrieving a little bit the needle and going through that point just perpendicular to the joint. We will see our needle with the lightning, with the reverberation artifact just inside the joint. We can see here also the needle inside the joint, and then we make inside the joint our infiltration. This is the second way. I personally make it more often in this way. I put the transducer just perpendicular to the clavicle, and then move lateral just till I see the joint, this hypoechoic space, and then perpendicular to the joint in controlling it in the in plane, in the long axis, just through this point, putting the needle inside the joint. The best is that we can control just not to trespass the whole joint, and we are sure controlling the whole needle that we are inside the AC joint. Posal injections are also very easy and very often done. We have to target the vertebral space between the dorsal wall and the rotator cuff. This is this hypoechogenic space over the cuff and underneath the bursa. This is our target, and in this target, normally we, in the long axis, we put a needle just in this hypoechoic space. We feel a little bit, and we are sure that we are inside the bursa. Then we feel 7-10 centimeters with anesthetica and with usually 3 Amson alone inside the bursa. The long head of the biceps tendon can always also be infiltrated just inside the sheath, or just to aspirate the fusion. The position is in the long axis. The transducer is perpendicular to the arm, and in an in-plane technique, just we control the needle just going over the biceps tendon, or making our infiltration just surrounding the tendon in